All right, everyone. So thank you very much for joining our webinar tonight. And my name is Alana. I'm a research and campaigns coordinator at the Ontario Health Coalition. And again, welcome to this webinar on safe consumption sites in Ontario and how they're under a major attack by the Ford government, who plans to close at least 10 of the 23 sites in Ontario. And so tonight we'll discuss what the Ford government has done, the privatization of addiction services, the impacts of these closures, what we can do, and much more. And so I'll just begin this webinar by acknowledging that we are all meeting on Aboriginal land that has been inhabited by Indigenous peoples from the beginning. And I'm speaking with you from the traditional territory of the Ojibwe, the Anishinaabe, and in particular, the Mississaugas of the New Credit. And this territory is covered by the Upper Canada Treaties. As settlers, we're grateful for the opportunity to meet here, and we thank all the generations of people who have taken care of this land for thousands of years. And we also recognize the contributions of Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community in particular, and our province and country as a whole. As settlers, this recognition of the contributions and historic importance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities. And so with us tonight is DJ Larkin, who is the Executive Director of the Canadian Drug Policy Coalition. And as a legal advocate and lawyer, they've worked on issues impacting people experiencing criminalization and systemic marginalization for over a decade. DJ has represented Indigenous governments, both elected and hereditary, in litigation regarding rights, land, and resource management. In 2017 to 18, DJ also co-investigated and co-authored an in-depth report on systemic exclusion and marginalization of people living at the intersection of poverty, housing insecurity, and criminalized substance abuse, aimed at creating systemic legislative and policy reform. And Natalie Mera, who is the Executive Director of the Ontario Health Coalition, unfortunately cannot be with us tonight right now because she is unfortunately stuck navigating a hydro issue and a car accident on the highway right now. So the structure of tonight's webinar will be about 45 minutes of an interview style Q&A between myself, who will ask the questions, and DJ, who will answer them. As mentioned, we'll discuss what the Ford government has done, the privatization of addiction services, the impacts of these closures, and what we can do, and much more. After those 45 minutes, roughly, we'll have about 15 minutes of discussion where everyone can ask questions. And before we start the discussion, we'll also show you how to ask questions in the chat or by raising your hand. And with that, I will begin with the questions for DJ. And thank you so much for being here with us tonight.
Great to be here. Great to meet all of you. Thanks for having me.
Awesome. So let's start off by talking a little bit about some of the key terms and issues we'll be discussing. So the first question I have is, what is a supervised consumption site?
Yeah, so I guess the most basic level, it's a facility where people consume drugs. These are drugs generally from the unregulated drug market. They have supervision and they can receive timely care if there is a toxic medical emergency, a toxic drug poisoning event, often called an overdose. There are trained workers who can respond immediately. This means folks can prevent death and brain injury by administering things like naloxone and oxygen. And it goes further than that. So, really briefly, we are in what we call a toxic unregulated drug crisis. So over the last 10 or 15 years, the illicit drug supply has changed dramatically. So what we're seeing is much more potent, much more unpredictable substances. And those, because drugs are criminalized, because you can't sort of access them in a way that you know that there's consumer protections over them, you know the ingredients, it means that new drugs keep emerging. And so now we're seeing things like fentanyl replacing heroin. We're seeing adulterants like nitazines and benzodiazepines enter into that supply, and that makes things more complicated. So when it comes to supervised consumption sites, it really is that first line of defense to maintain safety and save lives. In Ontario, sites have managed more than 23,000, I want to say 965 overdoses in their facilities. And that's despite the increasing toxicity of the supply. Nobody's dying in those facilities. No one. And beyond that, critical prevention of harm and injury. You know, they provide health and social supports, people do wound care, provide referrals, and they can provide that longer term monitoring to make sure that people get the intervention they need. And, you know, people can monitor to see, do we need to use naloxone? Can we use a different intervention? It's a much more nuanced way of supervising somebody than simply calling 911 if you see someone on the sidewalk. And then ultimately, there are places where people provide things like referrals to substance use treatment, primary care, wound care, things like that.
Perfect. Thank you. Yeah. Life-saving services.
Essentially, that's it.
Yeah. And that leads into the next question. So when you say harm reduction, like what do we mean? What do we talk about?
Yeah, that's a really interesting one. So, in terms of the services and like how we conceive of harm reduction, it's often about it's taking an approach that helps people be safer by reducing potentially harmful impacts associated with a number of human behaviors. That could be substance use, it could also be sexual activity. So things like condoms or sterile needle distribution are methods that have been established for decades to reduce harm of things like HIV transmission or other harms related that may arise related to substance use. I try to say, like, if you were trying to explain this to, you know, your uncle, you can think of it on a really sort of practical, basic level. Harm reduction is like seatbelts. Some people are harmed when driving or riding in a car. That might be due to something completely outside of their control or a decision they make while they're driving. But seatbelts reduce the potential harm if there's a collision. And then I guess more broadly, briefly, I'll just say harm reduction is really actually grounded. It's more of a principled approach as well. It's grounded in relationship building, helping people make informed decisions, not taking a punitive approach, regardless of whether someone is using drugs or not. And it's really rooted in human rights and dignity, saying that like whether you use substances or not, people are worthy of care without judgment, and we will help people make informed decisions that make the most sense for themselves. And that philosophy really comes out of decades and decades of community organizing because harm reduction started in community, didn't start with services. It came out of a philosophical movement during the early days of the HIV/AIDS crisis in the 1980s. And in the places in the US, it can be traced back even farther to mutual support like free breakfast and survival programs run by the Black Panthers. So, at its most fundamental level, it's about loving your community and finding ways to express that in a way that helps people be safe and well.
Exactly. And it goes along with the principles of public Medicare, which is, compassion, equity.
Yeah, totally.
Yeah, and the last question for this section is, you touched on this a little. So how do these supervised consumption sites relate to substance abuse treatment?
Yeah. So beyond what I already said, you know, harm reduction and supervised consumption really is part of a larger system. Often it gets talked about as being different than treatment systems, but it's really a part of that system. So it, like I said, you know, these are places where people facilitate like trust and relationship building. It's non-judgmental, and so it really is that access point, right? So when you think of supervised consumption services in Ontario, they've received what is it? Over 500,000, like 589,000 more service referrals. And so that's for health support, social supports, addiction treatment, withdrawal management, HIV, hepatitis C, uh, testing, housing, you name it. So they're a real referral and service point. And it means that they're places where when people are trying to navigate and get into a place like a bed-based treatment or community-based treatment, they have that space to go to get access and to be safe during while they're waiting, to be totally honest. So in Ontario, I believe the recent data shows that in the best case scenario, if you're around, if you can get that referral, it can take 253 days to get access to addictions treatment in Ontario. That's a really long time to wait, and services are needed in the interim. Um, if you think of like healthcare as a house, you have to get in the door. A lot of people have barriers to getting in the door. Supervised consumption is not only providing a bunch of services, they can be the ramp that makes it possible to get in the door.
Yes, thank you so much. And on to our next question. I think people will find this one interesting. So what is happening in Ontario right now around supervised consumption sites? Like, what are the basics people should know?
Okay. Okay, how do we do this? So we have a law on the books now. The Ford government has passed a new law that, on the most superficial level, bans supervised consumption from operating within 200 meters of school or child care facilities. That might sound really basic. It's more complicated. Right on the face of it, that means that 10 out of 23 sites will have to close. And that means that there's going to be some locations where the only site in town is now going to be closed and people won't have access to those services. What makes it more complicated is when you look at the context. So, Minister Sylvia Jones has gone on record saying that the government will not establish new sites. So, that means that even if they want to say that it's just about this 200-meter buffer, they're not going to approve any new sites, even if they find a new location. And in fact, there had been months and even years of delay prior to this law in approving supervised consumption sites. So, they've already been trying to avoid providing these services. And then the next thing is the province has announced heart hubs as a new service model. And well, I'm sure, we all welcome services, especially, services that offer intersections with homeless supports and healthcare. Those hubs are expressly not allowed to provide supervised consumption or needle distribution. So they are not the same thing, and they're not going to either, they may not provide services to the same group of people, or even if they do, it still means that people aren't going to get access to the services they need. If you think about it in terms of like barriers to shelter, if someone can't use in a shelter, where are they going to go? They're going to go outside or they're going to leave. If someone gets punished because they're under the influence in a shelter and they get banned from it, under those rules, they're not going to have access to that service. So even with heart hubs, we're not going to see people having the same level of access and the same type of access and services that they would with supervised consumption sites.
Absolutely. And what are the impacts of these planned service closures? And I know there's so many, but what are just some of them?
Yeah, I mean, I'll just say, like, at a really basic level, one of the big impacts is that this is legislation that goes against public health guidance. It goes against the evidence. It goes against the government's own documents. So, the Auditor General report, an Auditor General report has commented on government's knowledge and acknowledgement that closing these sites means that there's an increased risk of people dying. We just saw today an FOI request being reported on, showing that government knows that one of the ways they could actually improve circumstances for not just people who use drugs, but surrounding communities would be allowing inhalation services, but they're not doing that. So what it means is government is saying we need to close sites because we don't like that there's people in and around those sites and that people are seeing folks who are honestly like struggling at intersections of unregulated drugs, lack of healthcare, lack of housing. But if you close the sites, aren't you making that problem worse? It means that people have less access to immediate care. It means more reliance on emergency services, emergency rooms, more chance that people will incur preventable brain injuries from hypoxia and anoxia. It means more pressure on a healthcare system that everyone knows needs to be like defended and improved. When we're seeing emergency rooms close in Ontario, why would we close services that are demonstrated in the data to actually to decrease the burden on EMTs, decrease the burden on 911 and on emergency visits? Because a lot of the overdoses that would have to go to emergency rooms can actually be dealt with completely safely just at an overdose or supervised consumption site.
Exactly. And I think maybe some people will be wondering about this next question, and I think you touched on this earlier as well, is what is the evidence regarding safe consumption sites?
Okay. Yeah, there's a lot of it. Okay, so where do I even start? Um, for many, many years, there's been studies that demonstrate that supervised consumption sites, obviously, they're saving lives. Despite the dramatic increase in the unregulated drug supply toxicity, people are not passing away at these sites. They prevent HIV and hepatitis C transmission. There's good data showing that, like I said, they reduce that emergency department visits. They reduce actually the cost on the healthcare system as well. I have a number somewhere, I'll find it. It's in one of my tabs in terms of even looking at like what the different costs are to providing services in these different ways. The evidence shows that they also prevent complications. So when you think about healthcare, when you think about what universal healthcare means and what the ethos is of it, supervised consumption sites prevent complications. So it means someone is coming in, receiving non-judgmental care, and they can get wound treatment before it comes an abscess. Early screening and treatment for Hep C before it becomes acute. And there are studies showing that there's a higher than normal Hep C treatment uptake when it occurs in a supervised consumption site. So there's a lot of data around how these services work, and it's way beyond naloxone administration. It connects people in a lot of ways.
Absolutely. And also, if we don't have these sites, where do people go? What are their options?
Um, yeah, I'll premise this by saying, some of my previous work was working with people who didn't have housing and lived in encampments. And I will tell you where people go. They end up in public spaces where they are less safe, where people can be victimized by violence. And I'll say that there's a real gendered impact to this as well. Right now, with benzodiazepines in the drug supply, that means people can be sedated for a very long time. If they're in public, that puts them at great risk of assault, sexual assault, robbery, because they're not in a place where there's folks around and where they have that level of security. It also means that people use in places where there isn't that type of intervention. So one of the things that people are really scared of, we like people in our communities are scared every day. People will go and use in bathrooms and other spaces where they can get some privacy. It's a little more sterile. Maybe there's running water, but there's no one there to respond. And it means that librarians, people in like those other sort of public buildings, may be coming upon people who've passed away in the bathrooms because that's where people end up being.
Yeah, thank you. Um, and our next question, I think we've also touched a little bit upon this, and feel free to expand more upon it. So how do these supervised consumption sites support the public healthcare system? And to follow up with that, how does it connect to the privatization of our public healthcare?
Yeah. So, beyond some of what we already talked about in terms of how it provides services and can prevent these, you know, can prevent health situations from becoming critical, they also really do have an impact in terms of savings, which matters when we're talking about how do we resource the public health system. So, every dollar spent in a supervised consumption site can be associated with, just over like I think $5 in public health savings related to new HIV cases and deaths. So let's invest that and just keep that system getting stronger. Um, Now I'm remembering, thinking of like fewer emergency room visits. A study out of Lethbridge showed that there was a 50% reduction in opioid related emergency department visits when the supervised consumption site opened. So that type of thing really, really matters. And then even more broadly, um, it- there's an impact for the frontline folks. Um, Dealing with an emergency, dealing with people who are having preventable injuries, who are dying preventable deaths is extraordinarily traumatic for people in communities with people who use drugs, friends and loved ones, and also the frontline responders. So when we think about those workers, people who are every day doing their best in a really hard situation in the public healthcare system, supporting them means supporting services like this and investing in making sure that people don't have to go to the emergency room. And then, sorry, to your question about privatization. Ooh, well, I don't know if people know this, but actually, a lot of substance use treatment is private. It's not really part of how we conceive of universal health care right now. Um, a lot of folks in this room will probably know that under the Canada Health Act, there's a real focus on physical healthcare needs and things and services provided in hospital. There's really not universal coverage for addictions care. And so everything gets treated as an exception. Everything is an exception. Even to operate a supervised consumption site, because our legislative scheme treats drugs as prohibited, means you have to get an exemption from the criminal law for every single thing that you do. And that means that people aren't getting required care. When I think about advocating for universal care, I don't think only about like pharmacare and dental care, which are extremely important. Yes, more of that, please. I think about what does universal mean in terms of making sure everyone has access. Privatized treatment, which is most of what people can access if they can afford it, can cost upwards of $25,000 a month. It's not properly regulated. People can end up remortgaging or losing their homes. It's putting a ton of money into essentially an American style healthcare system, and it's leaking that money out of a system that we all care about and need to defend. Um, and it's really expensive if you end up having to treat someone in hospital as opposed to community-based programs, like about $350 a day as compared to about $120 a day. And I guess the other piece of it is when we think about the universality of healthcare and what supervised consumption sites provide, they're thinking about social determinants of health. They're thinking about the person. They're thinking, oh, what about housing? What about income? What about these other things? And that actually is part of what it means to be well. And so they are one of the services that actually can really engage with some of those social determinants of health in a really meaningful way, whereas not all services are able to do that as much.
Yeah, thank you so much. And yeah, like these supervised consumption sites are healthcare. And what we you mentioned that American style privatization is it reflects what we see in our public hospital service privatization with the private clinics that are coming in. And it's really many parallels are drawn between that.
Yeah.
Mhm.
It can be a real wedge issue into privatization because if people aren't paying attention to what's happening around places like supervised consumption sites, they may not even realize this is a wedge issue to put a lot of money out of the public system and into the private system, into places where there's no real regulation or oversight about the quality. And it means that, you close a supervised consumption site, that was probably a good union job. And now we're moving more dollars into private hands.
Exactly. Yes, exactly the same thing that is happening with the privatization of public hospital services. Mhm.
Really. Yep.
Yeah. Mhm. Yeah, and then switching gears a little bit, kind of into the part about the legislation that's currently underway right now. So how can a provincial government just remove access to a life-saving service like this? Like, aren't they legally protected?
Yeah. I mean, there's been a number of cases talking about why these services need to be legally protected. They are life-saving. Making decisions that sort of arbitrarily take away services like this do breach people's rights. And when we talk about rights, it's not some like conceptual would be nice to have. We're talking about the right to life. That means government shouldn't take action in a way that could take your life away. And that is what we're really dealing with. Now, why can government do this? Honestly, again, it comes back to this overarching structure. These sites are not considered part of that universality of care, and so they get this like project-based funding. They have to keep reapplying for exemptions from the criminal law, and so everything gets treated as an exception. It makes it way easier for governments to come in and enact legislation like this to try to limit, restrict, or prohibit these services. And so we keep having to go to court to fight the same issues again, to reiterate why these services are essential, because on that base level, we know they save lives. We know that governments shouldn't be cavalier about limiting services like that. But we just haven't made them so universal that they are um, just seen as like guaranteed and of course, and actually resourced in a way that would make them both more effective and, um, better integrated in community.
Yeah, thank you. And I think somebody has mentioned in the chat, and you've also mentioned it. How does this connect to human rights?
Hmm. So, going back to like 2011, the first sanctioned, I'll say, supervised consumption site, Insight, here on the lands where I live, on Musqueam, Squamish, and Tsleil-Waututh territory in Vancouver, ended up going to the Supreme Court of Canada around whether or not refusing to give one of those exemptions so that Insight could operate was a violation of human rights. And the court found, yes, it was, because similar to what we see now, where you see politicians talking about like we're going to shut them down, and using really, really inflammatory language in describing these types of services. Back then, we saw a federal minister saying like, "I'm going to shut them down," writing it in the margin of a memo. We're not going to give needles to. I'm not going to keep using the language that they used in the memo, but we're seeing really similar circumstances where there's a real stigma and a real misunderstanding and misinformation that then becomes law or becomes a government decision. So 2011, the Supreme Court of Canada said, nope, that decision violates charter rights. You have to give this exemption. And so now in Ontario, one thing that the court will have to consider is it reasonable for this legislation to come in place and shut down these sites, or does the Ontario government have to find a way to make these services available? Whether that's by striking down this law, or if they say, you know, if you require sites to move, you have to fund them, facilitate them, and make sure that they can have like a seamless move to another location if that's possible. Courts could do that. And then at the broader level, Canada has signed on to the International Covenant on Economic, Social, and Cultural Rights. We have obligations to build up the highest attainable standard of physical and mental health. That's what a lot of folks, I'm sure, in this room are advocating for in terms of the right to health, universal health care. We have an obligation there. This legislation doesn't do it. It just really punishes people who are at this intersection of systems failure, housing crisis, income crisis, toxic drug crisis, healthcare crisis, and this law makes it even worse. And then last thing I'll say, I guess, is the Truth and Reconciliation Commission report calls on the federal government to address health disparities between Indigenous people and non-Indigenous people. And First Nations people in Canada are 7 times more likely still than non-First Nations folks to die from toxic unregulated drugs, and 9 times more likely to be hospitalized. That has a lot to do with stigma, a lot to do with policing, and a lot to do with not having access to the treatment and care that is most meaningful at the intersection of ongoing and like critical levels of discrimination and colonialism that is impacting communities.
Absolutely. And that segues into our next question. Where is this opposition coming from? Can you expand more on that?
Yeah, and I don't want to be cavalier about it. So, I mean, I'll start with the politicians, but then it's also important for us to talk about, uh, people's really uh, honestly held questions. So, at that political level, there's opportunism happening. There's some politicians want to take people's worries or discomfort or, concern and manipulate it. They want to offer what seems like a simple solution that allows them to sidestep their accountability. So in this instance, politicians want to say, oh, are you scared about that? Cool. We'll blame the people who are most harmed and we'll sell you a fake solution. We'll say everyone will suddenly be abstinent, or we'll sell a solution that policing will solve it. And those simple solutions can seem really tempting, but you always say when someone tries to sell you a simple solution to a vexing problem, it's usually a lie. So that is a way to get people to feel fear, and then you capitalize on that fear to try to get a vote. And it is happening across the country and more broadly. We see a lot of like scapegoating, like I said, government has failed around things like housing, so people are in public spaces, and now they're scapegoating supervised consumption sites. We see the same thing around encampments. People are living in public spaces because we have a housing and shelter crisis, but we end up sort of blaming the people who are most impacted. And then sort of more like at the like us and our community and our dinner table level, I think we can all hopefully agree and have confidence that we all want to live in a safe, thriving community, no matter what our relationship is to any substance, whether it's an unregulated drug or even alcohol. So we just have to think critically about how we get there, because some opposition is coming from folks who are just honestly deeply uncomfortable with witnessing like poverty, suffering, with witnessing people who are being harmed and failed by systems, and that, they may not understand, like, why is that person sedated? Why is that person acting that way? And people can feel uncomfortable. And I get it. Um, Seeing preventable suffering is terrible. So the question is, what are the actual responses that would help and not hurt people? Because there is opposition that does come from people who quite honestly are uncomfortable and aren't sure what to do about it because the government's not taking the actions that we need.
Exactly. Thank you so much. I think it's a hugely important point to touch on. And it also transitions nicely into our next question, which is what should we be advocating for?
Okay. What should we be advocating for? I mean, at the most broad level, and I don't think I have to be selling this to this room, we need to continue to strengthen our universal healthcare system. We need to strengthen the ability for people who are doing incredible work to do more incredible work. That means equitable access to a range of supports and services. So, like I was saying before, when we think about universality, it's not just about what types of services, it's about who gets access, who's on the boat. Let's not like push anybody off the paddleboard. We all have to stay in this together and make sure that no one's left out. So, advocating for a range of supports and services, not just about substance use. So even if we're talking about supervised consumption sites, we need to be thinking about those social determinants of health. If someone's saying, but I'm seeing someone in public space, but this doesn't seem to be working, but we haven't really resolved the crisis, we need to be advocating for not just physical health, but universal mental health care. We need to be thinking about the intersection with those social contexts, housing, income, cultural safety, and community support. And within that, when people talk about healthcare, we need to remember, and treatment, we need to remember that it's the full spectrum. It's everything from supervised consumption and harm reduction all the way up to universal voluntary evidence-based treatment, all the way through. Some people will want abstinence, not everybody will. So it has to be that full spectrum of services. And really, at most basic level, if we're advocating for universal care, this shouldn't be optional. And we should be asking questions, not just of our governments, but of our workplaces about where are we putting dollars into private healthcare and how can we avoid it?
Exactly. Perfect. Um, and I think you've touched on this. A couple of people in the chat have touched on this as well. There is a charter challenge regarding this new law that the Ford government has brought in. So can you share a bit about that?
Sure. So just as like practical steps, the challenge to Ontario's new law, which they call the Community Care and Recovery Act, even though it doesn't provide care or recovery, it just limits supervised consumption services and a number of other services and policy alternatives for people who use drugs. It's going to court next week. The court will be hearing arguments Monday and Tuesday. And so the neighborhood group community services alongside two individuals who access supervised consumption sites filed a charter challenge. The basis is section 7, so that's the right to life, liberty, and security of the person based on denial or restriction of access to services that save lives. Section 15 of the charter, which is the right to equality and freedom from discrimination based on the targeting and the denial of services for people who identify as having a substance use disorder, disability. And also, they're going to be arguing that essentially this is trying to interfere with the criminal law. So, like I said, at that federal level, there's an exemption that says you can get exempted from the criminal laws around drug possession in order to do things like supervised consumption services. This legislation makes it harder to get that exemption, and that's messing with the criminal law. And as was found in the Insight decision, that ability to get an exemption is essential. The court called it the safety valve that protects the constitutionality of the federal law. Because if you can't get an exemption from it, it could be that that law is actually too harmful and is unconstitutional. So that'll be Monday and Tuesday. and they're seeking an injunction, which means they're seeking a court order temporarily saying that the law cannot operate. It's potentially too dangerous. And then the court will need some time to review all of the evidence and make a decision about whether the law is constitutional or not. That could take a few months.
Yeah, thank you. Some of you may recognize the neighborhood group. They're one of our partners. They're, yeah, great supporters, and we support their work as well. So yeah, thank you.
And it's a
And yeah,
And service providers come forward and take on these challenges. Very often, it's people who don't have housing, people who use drugs who take on these challenges. And it's so important to have the support of service providers and healthcare providers. So, yeah, it's a really big deal.
yeah. And what will the Canadian Drug Policy Coalition, alongside with the Intervenor Coalition, argue in this case?
Yeah, so we're thrilled to be working with the Toronto Harm Reduction Alliance, Toronto Overdose Prevention Society, and the Waterloo Region Drug Action Team. And essentially, as an intervener, we're not on either side. We're here to like help the court make a good decision that's grounded in evidence. Our focus is going to be on what are the principles the court needs to follow to make a decision that is actually informed by public health. So the court needs to look at this law and look at the evidence and say, does it prevent harm? Or does it actually cause harm or stop us from preventing harm? Because that's a big deal. You can't have a law that touches on public health that actually causes harm. Second, is the law clear enough that people know what they can do? So when you think about public health emergencies, and we've all been through a few of late, law and policy needs to be clear enough that people who are providing those services know what they can do and not do. This law is way too complicated. People can't even figure out if the legislation prohibits getting exemptions for drug checking. It's really unclear. It puts everything in flux. If a service doesn't close tomorrow, will it have to close next month? All of that kind of thing. So law needs to be clear enough that people can actually take action downstream and provide services. The third principle is this should be simple, but it's actually hard to identify sometimes. Policy needs to be based in evidence, not stigma. We find all over the place that assumptions get made and people see it as almost like folk wisdom or common sense, but it actually might be prejudice that we're just really used to hearing. Even things like someone having drugs in their pocket is a public health risk or is a public safety risk. Is it? Because there's not actually evidence to support that as being a public safety risk to another person. But we treat it that way and we make assumptions. So we're asking the court to really dig in and actually question what's true and what's something that I just believe because I've heard it too many times. And then the final piece that we're going to argue is that the court needs to think about public safety and public health together. If they want to protect public safety, it can't do it in a way that actually decreases public health or like has negative public health outcomes. And at the same time, when we think about public health and safety, we should be looking at law and policy through a lens of what would actually create the conditions of safety. Not, well, we failed on housing, we don't have enough access to treatment, we're not doing great on shelters, and we don't have enough services for people. So let's layer a law on top of that that further harms the people who are already experiencing those harms. Instead, we should be looking at law and policy and going, what would actually create the conditions of safety, which would be better resourcing for supervised consumption sites, more access to treatment, more space, more housing, more access to build up what everyone agrees we want. Finding alternatives for people who are in public spaces, preventing brain injuries, helping people access treatment when they want to. This law doesn't do it.
Exactly. Thank you so much. And I think with that, we'll move on to our last question. So how can people learn more and get involved?
Oh, I mean, people are already here, so they're involved with your coalition, and they are involved. If you want to learn more, there. Hopefully, Jess can maybe drop some links to our website. I also know that the HIV Legal Network has put up some briefs on their website outlining what's happening in court next week. You can follow our social media because we'll be following the case, and well, I'll be there in Toronto. Folks can come to the courthouse if you really want to on Monday and Tuesday to watch the proceedings, though I think the courtroom will be full. because a lot of folks want to come and watch it, which is great. But, court processes are open, so you can come and watch. And when you're engaging in like dinner table conversations, and I know that that sounds like it's not systemic enough, but especially when we head into election times, dinner table conversations matter. Reading these resources and being able to answer the question of like, oh, that actually might be a misunderstanding about the situation. And here's how defending our public health system, dealing with social determinants of health would actually help. Policing people actually won't, or forcing people into treatment. There's no evidence of that. So we've got a lot of resources on our website. We do quite a bit of just sort of like micro learnings in like TikTok videos and things like that to help people with just like answering some of those dinner table questions, because that's where hearts and minds change, is when we can have those conversations. And I guess way more broadly, we will have a new federal government at some point, probably quite soon. They're going to have to pass a budget really, really soon. And they need to fund these services because they can't be optional. So even if the Ontario government isn't going to fund these services, somebody has to, because they need to stay open. And right now, services are already closed or closing this week, not just because of this legislation, but because the government isn't funding them. And there's opportunities to make submissions around what governments should be funding in their budget processes.
Yeah. Is there a way for people to watch the proceedings via Zoom by any chance?
My understanding, it is actually going to be streamed online, and we're just waiting for the link. I don't have the link yet, so we're watching for that. And if it's helpful, we can pass it along when we get it.
Yeah, absolutely. Thank you. And before we move into the Q&A portion, is there anything you'd like to add?
Oh gosh, I've said so many words. I can't think of anything, but if there's questions, I would love to hear what questions people have. Thank you so much.
Yeah, no, thank you so much. So yeah, now we'll just move into our open discussion portion. Yeah, so Jessica and Sala have been looking at the chat and just responding to messages. I will just I think I'll just come to both of either of you. If there are any questions you'd like to bring forward from the chat, they can just like present them to DJ maybe one at a time. And to give you both maybe a little bit of time to gather those questions, we'll just go to the rest of the participants. So if you're not familiar on Zoom, at the bottom of your screen, there's a bar and one of them has a heart. It says react. And if you click on that, there should be an option to raise your hand. If you do that, you'll appear on our screen, like near the top, and then Sala will unmute you, and then you can ask your question. Okay, so Mark, we'll start with you.
Yeah, hello. I'm gonna keep my camera off because I'm pretty tired right now. So but yeah, I would love to get I'll turn my camera on. I would love to get more involved. I got this from a peer that shared it within something she got. So I'm not necessarily on the coalition or anything, but like I am in Northern Ontario, and I'm interested in learning more and being able to have stuff like those stats and being able to contribute at least from a mental health and harm reduction from an alcohol standpoint. And just the overall conversation and getting, like you said, stigma. Um, and so uh, if there's ever anything I could do, let me know. But also, I just wanted to say, like, what do we do outside of um, like, if we can't have those dinner table conversations and stuff like that? What can we do to provide information that might not overload people with stats? Like myself, I have ADD, so I personally might forget the stat by the time I want to go and tell somebody, right? So what's something that might help not overload them with information, let's say, because I can relate to the dinner table conversation not going well because people in a higher class just don't get it sometimes. And yeah, I hope I didn't ramble, but thank you very much. And this was very informative. And yeah, thanks.
Yeah, thanks, Mark. And that was fantastic. I mean, in terms of resources, Jess is, I know she's putting stuff in the chat that might not be accessible to everybody, but we're happy to follow up with like links and resources. And in terms of Northern Ontario, there's some incredibly powerful advocates up there. In places like, Thunder Bay, Sudbury, and Timmins, and in the north who are advocating around these things and have so much to offer in terms of those like you were saying, like how do we have a practical conversation where we don't have to remember all the stats? And I super feel you on that. I have like lists of things where I'm like, my brain will not remember this. I need to write it down. So we're happy, like we can follow up with more information. Happy to be in touch with people. There's definitely, in Northern Ontario, some incredible advocates that I'm not going to try to list them right now because my brain will get it wrong. But that you might be able to connect with even to just build some of that like relationship and community solidarity. In terms of like what can we do that isn't all the stats and super overwhelming? The stats don't usually change people's minds, right? And they're important, but often where I end up like connecting with people is just like, can we agree that we actually want safer, healthier communities? Great. Can we agree that like taking away services probably isn't going to get us there? Great. Okay. What are you most worried about? Are you most worried about someone being outside in public space? Okay, well then why wouldn't the answer be housing and healthcare? Or are you worried that like people are going to continue to use drugs or alcohol? Okay, well they might. So what do we do? What do we do to help keep people healthier and safer? And how do we make sure the door is open if someone decides they want to change their relationship to drugs or alcohol? Because we have to create a relationship so that if someone wants to make that change, they have someone who they can call right away and say, hey, I want to make this change. And oftentimes it's not about the stats, it's just about agreeing that we actually all want things to be better and then trying to get people to realize that punishing people doesn't actually help it get better.
Thank you, Mark. Thank you, DJ. And I see Mark has left their email in chat as well, so we can connect. Yeah, great. Susan.
I'm trying to understand how the safe injection site operates. So, two things. Number one, how do people come to the site? Are they referred? Do they walk in? Is it an appointment thing? Do they show ID or anything, or is it just anonymous? And then the second part is, what does a typical site look like? Like the number of staff, the operating hours, is it 24/7? Is it comprised of nurses, doctors, like certain professionals? Those are my two questions.
Big questions. And the answer, unfortunately, is going to be it depends. So I can't speak to how every single site operates because they can be a bit different. In terms of how do people come to them? No, they're not referral or appointment based because, again, coming from that harm reduction perspective, like it's about people having access immediately. And especially when it comes to supervision and making sure that someone can be there if you need naloxone or oxygen. You don't make an appointment for that, and it really has to be as low barrier as possible. So people walk in. It does mean that if someone goes, is a regular client, they get to know them. You can then, through the site, make appointments for other things like primary care, like access to treatment. But they're intended to be really like, come on in. People often, I don't know at every single site in Ontario. I know the sites that I'm more familiar with. People don't provide ID and often will even use pseudonyms because they're afraid of the criminal law. Again, we want people to access services, and if people are afraid of getting arrested, it limits their access to those services. Again, that doesn't mean that they can't go on to use their health card to access other care. In terms of who staffs them, It depends. It depends on the site. You can have everything from, nurses and nurse practitioners and really professionalized healthcare, but also peer-based supports, because often peers really, really know a lot about how to take care of each other. And going back to where harm reduction came from, it came from that community love and support. And so really taking the love, expertise, and experience of people with direct experience and finding ways to help people make informed decisions and be safer. So some sites employ peers and frontline service providers who may or may not be nurses, but are trained in first aid, they're trained in CPR, they're trained in naloxone administration, they're trained in how to identify like the signs of an overdose, things like that. So it can be a bit variable in terms of who the staffing is, but it's always folks who know how to respond, know how to identify, and know who to call, and they know what phone numbers to call to try to get those referrals if and when things like treatment or housing are available and desirable. I don't know if that answered your whole question. If it didn't, you can put it in the chat. The answer is like, it depends. Oh, hours? No, they are not 24/7. It really depends on staffing. It depends on resources. They're not 24/7. They're not available everywhere. And so we do know that there are times when people are at risk and when in fact we are losing friends because sites are closed. So yeah.
Thank you. Thank you, DJ. Thank you, Susan. I'm just gonna go to the chat, see if there are any questions that have popped up. I think they've been popping up since the beginning, I think. So Sala and Jessica, are there any questions from the chat?
Yeah, okay, so there was a question, one second. There was a question just asking, what are other provinces doing when it comes to safe consumption sites? Are there different models that are used? Do they use the same model that we use?
Different. So this is another issue with the sort of like concept of universalities. So Ontario has sites, but they have this layered on level of what they call CTSs. Shane put it in the chat. I forget what it stands for. Consumption treatment sites, something like that, which layers on all of these like additional requirements for what is required in order to run a supervised consumption site. In BC, we have a different model where there was an emergency order in 2016 to establish overdose prevention sites anywhere where the data indicates they are required. No, we haven't fulfilled that order, not by a long shot, but it has actually allowed for the province to approve overdose prevention sites that are really low barrier and can be opened pretty quickly without having to go through the federal exemption process. And then you have places like Alberta where they're really trying to cut down on these and really trying to limit access to services like this. And instead, they're really moving towards an explicitly privatized abstinence-based treatment model. So there's a lot of variety across the country.
Yeah, thank you. Any other questions, Sala? Maybe we'll take like one more.
I think we're good for now, but you can come back to me after the people that have their hands up.
Okay. All right. Eugene.
Okay, hold on.
Oh, there we go.
There you are.
Okay, as an injured worker advocate, we have a lot of workers in this province who, for no fault except went to work and got injured, are now addicted to all kinds of drugs and alcohol just so that they can work. Because recreation, maybe, yeah, but they had that one time in their life, but I don't think it's a recreation drug anymore. So what happens, you keep using this, say they give you a oxys. They keep giving it to you, they keep giving it to you, you keep taking it, your tolerance gets higher and higher. Now you can't go to your doctor and say, okay, give me some heroin or some morphine, because that's really going to work. So where do you go to get that stuff? Well, you go where you can. They're now putting those naloxone kits and heart defibrillators in construction sites. That just that alone is a problem. And it's not so much just in construction. We're talking every heavy industry, from steel, making steel to typing manuscripts, right down to forest extraction, mining. They have workers. I've been hearing workers have issues, and they can't say anything because if they do say anything, they get cut off. So they got the carrot. And now this on top of this. And in the age 60, if you're 65 and you get injured, you get 2 years. That's it. Even if you cut yourself in half, you get 2 years benefit. That's it. So yeah, I mean, we got a big issue in this province, and for some reason, he got a 4-year mandate. I personally can't believe that the people of Ontario, especially 416 and 905, put him in power. They should not be allowed to use anything, cut off all services there. Thank you.
Eugene, you are speaking truth. I mean, just, really briefly, like, workers are so harmed by this policy environment. And it's everything from, like you said, when we think about healthcare, what about those services that aren't like hospital services and aren't prescriptions? What would actually help people manage their pain and be at work? Then when you think about workplace policy, a lot of folks end up in a place where you can end up being like punished, or you have to pay for medical monitoring out of your own pocket if you are identified as someone who uses substances. There's often often if someone does end up in like substance use treatment through workplace, that's private healthcare. That's worker money into private health system. There isn't a lot of support, and people can end up like falling out of the workplace and that like family union environment that people rely on. And people are scared to come forward and say, I'm struggling, because they don't want to get punished. People don't want to lose their jobs. And we don't have the supports in place that people need. We see it, like you said, in trades and heavy construction, but it is happening in all sorts of workplaces. And our policies are just like not properly addressing how do we help people actually be well, be in the workplace, provide the supports that people need. And how do we stop having even like workplace health programs funnel money into that private system that isn't really working for people, because it really, really isn't. And if we stopped funneling money into that private system, how much more could we provide in terms of the benefits that you're talking about in terms of physiotherapy, other care, access to proper disability benefits, all of it.
Exactly. Yeah, thank you so much. I think we'll go to Tim, and then we will go back to the chat. Thank you for waiting, Tim.
Oh, hi, you hear me?
Yep.
Okay, I have long been aware that most of the problems with addictions happened after narcotics became illegal. At one time, it was perfectly legal to have any kind of crap you wanted. And this problem began to develop when it became profitable to get people addicted. When it was money in, it became money in trafficking it. Any idea when exactly this became illegal? I haven't really been able to find that out. Also, are we looking at a time when we might have narcotics decriminalized, the possession of it decriminalized again? And will this case you're talking about help?
Yeah. Okay. Yes. So Shane's popping some stuff in the chat. We didn't have prohibition forever. And in fact, we can actually directly link like the criminalization and prohibition of drugs with this dramatic increase in not just unregulated, more toxic drugs, but also like substance use harms, mass incarceration, racism at the intersection of policing and mass incarceration. Like they just track right together. So 1907, we see people starting to talk about prohibition. That comes a lot out of two things. One, early Indian Act bans on alcohol to control Indigenous communities. Two, we actually saw a race riot in the town that I live in, and they were talking about how we have to get rid of opium dens. So they started talking about prohibition really around actually racism against Chinese and Japanese businesses. So then the Opium Act came in like 1907, 1908. And that was after the Opium Wars, where the UK lost control of the opium market and figured, well, if we can't make money off of it in this way, we'll make it criminal. And so we've just seen it ramp up since then. All the way back to 1973, the Ledane Commission has been naming that this system doesn't work, and we haven't undone it yet. But what's on the horizon? More and more people are talking about how we actually need to move to more of a consumer safety regulatory model, because that would actually control not just the contents of the supply, it would control access properly. Because right now, under the criminal law, it's not like we're controlling access properly. Drugs exist everywhere. If we can get drugs into prisons, we can get them into anywhere. And people do. No one's checking ID. So if we actually change to a regulatory model, we could properly control both contents and access. More and more people are talking about that. We're working on a detailed platform for like, what would the step-by-step process be? And what would the actual pieces of legislation look like for a different system? And through litigation, hopefully we'll start to see changes, not just through this litigation, but in BC, there's a criminal trial coming up for the two founders of the Drug User Liberation Front. They were people who were arrested for running a compassion club that was providing tested, labeled, and like secured packaged drugs to a specific compassion club of people who were identifiable. Those were drugs who were like going to those members. It was very controlled. Nobody died. No naloxone requiring overdoses. The data coming out of Drug User Liberation Front Compassion Club was stunning in terms of how effective it was. One of the founders is trying to become a doctor right now and is also facing criminal charges for drug trafficking. So they're challenging the law and saying that the law is not constitutional and we actually need to move to something different. It's going to take a long time, but I actually think we're on the precipice of changing the system because we know it doesn't work.
Absolutely. That's very exciting to hear. Yeah. Thank you, Tim. And Saul and Jessica, any other questions in the chat? Otherwise, I think I've got one last one Jessica sent to me.
Okay, there was a question just asking, if it's not too personal, DJ, what brought you into this line of work? And if you are uncomfortable, I would just ask, why is this an important issue more broadly?
Yeah, I usually don't talk about myself, like everyone brings their own stuff. I mean, I'll say like, I don't know anyone who isn't touched by this issue. And, I definitely come from a background where substance use is like very much part of my family's experience. And I really wish that I had had somebody to talk to about how to approach that well and in a more caring and loving way and in a way that really embraced harm reduction. So sort of like vaguely, I can say that for sure. And then in terms of like more professionally, I worked with people who are in prison doing human rights and healthcare advocacy, and then with people who don't have housing. And to be honest, drug policy and harm reduction intersects with so many things. If we want to end homelessness, we also have to talk about drug policy. If we want to end like over incarceration, we have to talk about drug policy. If we want to talk about in universal healthcare, we have to talk about drug policy. So this is just like my heart and soul, and I wake up thinking about it every morning and go to bed sleep like thinking about it every night, because this is like me and my community and my loved ones, and these are preventable harms. So no choice, have to do it.
Absolutely. We're 100% supportive of that. Thank you so much. Yeah, Anne-Marie, we'll go with you.
Hi, can you hear me?
Yep.
Okay, great. I also wanted to add DJ is the mental health, because a lot of them do not like what the medications do to them. They feel like it numbs them, right? So they use street drugs to medicate themselves. I don't know if this is off topic, because I know we're talking about the consumption sites, but what have you seen an uptick in people having fentanyl overdoses when they think that they're taking another drug, but it's actually laced with fentanyl? Because I've heard that even marijuana in some instances has been laced with fentanyl. So has there been any of that happening where people think that they're taking something else, but they're actually getting fentanyl?
Yeah. I'm looking at the like Jessica and Shane in the background to also be like, if there's something that we can put in the chat, we can put some links in. I'm not aware of a lot of data around this question of like cannabis and fentanyl. It's not something that we see a lot. It is a story that circulates sometimes, but I'm not aware of a lot of data around that. And again, coming back to the context, when drugs aren't regulated, it's really hard to know what's in them. What we do see a lot, on one hand, it's what I call the chocolate chip cookie problem. If you're mixing something and you don't have access to good equipment to do it, it's like making cookie batter, but you don't really know where all of the chocolate chips are. So you could be mixing something that has fentanyl in it, but you don't know if the cookie you're going to get is going to have 1 chocolate chip or 10. And that means that you really can't predict what you're going to get. And we see, so for example, fake pills. So pills that get pressed and they get sold as something like hydromorphone, but it is actually fentanyl because it's not actually the like pharmaceutical that it looks like. And again, the reason for that is because we don't regulate the drug market, and it makes sense for people to make something that looks like a pill, but it often, may not contain what people think it does. I'm on a public health CDC text list, and I get text messages almost every day with drug alerts. Something sold as this actually contains that. Something sold as down actually contains benzos. Something sold as meth actually contains fentanyl. It's usually at the intersection of something sold as an opioid contains things like benzodiazepines or stronger opioids, or sometimes it'll be something sold as methamphetamine accidentally or for whatever reason actually contains fentanyl. That does happen.
Thank you, Anne-Marie. Thank you, DJ. We are nearing the end of the webinar. So Jessica, just any last questions from the chat? No? Yes, and Shane's put in the chat the Vancouver Coastal Health Authority drug alert. You can text add to 253-787. Yeah. Well, yeah, I think at this point we'll wrap it up. We will send out the Zoom link to the proceedings if they get that to you, and we can share that with everyone. I think people have been asking for the links that were put in the chat as well, so we can share those as well. And yeah, and so again, it's like, thank you so much to the Canadian Drug Policy Coalition for partnering with us and like helping us like have this webinar so we can, talk to everybody here about the life-saving healthcare services that safe consumption sites are and the major attack that they're under. Again, the proceedings are they're happening next week on Monday, Tuesday. So thank you so much, DJ, for answering all these questions and providing your, very vast expertise and knowledge on it. I think people have really enjoyed it, as you can see in the chat, and have found it like very informative and super helpful as we navigate these times in Ontario right now. And as you said, we move into potentially a federal election as well. So again, thank you so much, everyone. If you have any other questions, feel free to, I think, email the Drug Policy Coalition. I think Shane has put his email in the chat. Please also email us at info@ontariohc.ca as well. Our email's in the chat, and we can help connect people that way. Yeah, Shane's got his email in the chat there. And I think apart from that, feel free to stick around, but I think we will end the webinar now and we'll stop the recording. And thank you so much to everybody for coming out again on this Thursday evening. We really appreciate it.
Thank you so much for having me. This is a fantastic group.